ultimately, we want to be better. We want to get relief. We want to get treatment of our symptoms and try to make our periods more tolerable, get them better, get them at least within reason. And some of the options that we have available are medical management, so medications, pills, IUDs, as well as surgery. So we'll kind of go over those today. So birth control pills, tried and true, we're all familiar with them. They are a very easy, straightforward way to try to reduce the bleeding that we have, as well as sometimes even the symptoms that we have associated with heavy periods or irregular periods even, as well as dysfunctional uterine bleeding. There are potential for side effects, and there are women who aren't good candidates for them based on potential for personal medical history and things of that nature. But they are basically one of the first-line agents that we tend to use in many women who have irregular or abnormal bleeding. Also progestin. So not only can we use birth control pills, which have both estrogen and progestin in them, we can also use just progestins alone. So there's some names of some medications listed here that are just kind of broad spectrum coverage, but when we talk about using progestins to control bleeding, we can, but we don't typically use them the whole time of the month. We'll use them for about half, and that is that stimulation of that last half of our menstrual cycle where we're trying to get that progesterone effect, keep that GRAS mode, keep that endometrium suppressed so our periods don't become excessive and heavy and have extra bleeding. There are, again, side effects associated, just like with any other medication, headaches, some nausea, you can have some weight gain, mood changes, but most of them are pretty well tolerated within reason. Along those same lines, there is an IUD. So Mirena IUD may be something that you guys have seen commercials about or have read about. It is an IUD, which is an intrauterine device. It's a small T-shaped plastic device that's placed within the uterus by a physician. It actually has a small amount of a progesterone embedded within the device itself. And that progestin has a nice localized effect, so that release is local, mostly within the uterus. It keeps you from having to be on a systemic medication to help control your cycles. And it has minimal systemic absorption. There is a little, but it's minimal. And it can help reduce the blood flow in a lot of women, up to sometimes even discontinuing their periods. They stop bleeding even. Not everybody, but sometimes. But there can be some irregular bleeding associated with it. It is a device within the uterus, so sometimes that can happen. But it's pretty well tolerated by most women. Lystata. Lystata is a medication that was previously not available in the United States consistently until several years ago, or fairly recently. And it's a nice medication that keeps you from having to be on hormones. So if women are concerned about having hormone exposure, they're concerned about birth control pills, or may not even be a good candidate based on their medical or personal history, Lystata is a nice option to try to reduce heavy blood flow with your bleeding and with your cycles. So you typically will take it on the first 3 to 5 days of your cycle, and it can help control and reduce the quantity and discomfort and the bleeding associated with your cycles within a short period of time. And this is a nice option for women who either want to avoid hormones or are not good candidates for hormones based on whatever their personal history is. Other management options that are still used, a little less commonly, but still used, NSAIDs, or anti-inflammatory medications. So these are things like Motrins, Advils, Aleve, aspirins, things of that nature. These are medications that help suppress some of the other hormonal cascade or chemical cascades that happen during our cycles. Typically, to get the best benefit from this, you have to take them every day. You have to take them several times a day, and you want to take them as soon as your cycle starts to help reduce those hormones, reduce those chemicals from being produced. But it is within reason, again, if you want to avoid hormones, or if you want to try to do something over the counter that's more conservative, that you want to try to avoid having to get a prescription for, this is a decent place to start. And Lupron. Lupron is kind of a big gun. It's a big gun medication. It's an injection. It's a medication that almost recreates the hormonal balance or imbalance, whichever way you want to describe it, of menopause. So it suppresses the ovaries from producing their hormones to help reduce any stimulation of the endometrium. It's also used to help bridge women to surgery. So say you have big fibroids, or say you have heavy bleeding associated with big fibroids, and we're trying to get those fibroids shrunk down a little bit before surgery or something like that to help control your bleeding. This is an adjunct therapy. A lot of times it's used to help with that before you go to surgery. So now that we've talked about medication, the next things to talk about are, well, if those aren't working or we're not a good candidate for those, what are our next options? So surgery is another reasonable next step, or first step sometimes for some women. So dilation and curettage, or D&C for short. So this is a type of procedure where we go inside, going in through the vagina, take a little instrument to scrape or remove that surface lining, that endometrial lining within the uterus itself, to one, treat what's going on, try to get that extra tissue out, try to get that thick tissue out, so the women who are having problems with heavy bleeding hopefully will get control of that bleeding with that procedure, as well as diagnosis. So we take that tissue that we removed, we send it to a pathologist, and it also helps us diagnose, is there hyperplasia or precancerous change there, is there a cancerous change there that might be contributing to what's going on, and then treat it accordingly based on what the findings are. Polypectomy just means taking out the polyp. And so what we can do, back to that hysteroscopy, that camera that slides in through the cervix, we can slide those instruments and camera in through the cervix, grab that polyp, pull it out of there, maybe do a D&C at the same time to get the tissue out as well. And that can potentially be a good treatment source if the polyp is the source of the bleeding issues. There's a couple of ways that it can be done. Hysteroscopically is an approach as well. So there's actually instruments that we can use to remove these fibroids from the inside of the uterus, depending on their size, depending on their shape, depending on how far they stick into the cavity of the uterus. Sometimes we can get them out that way. Or if they're large and they sit within the wall of the uterus, or they're really bulky and we can't get them out via the inside of the uterus, sometimes we have to get them out from the outside. And so we'll do that bikini cut incision, or sometimes we can do them laparoscopically or even robotically, if you've heard of the robotic surgery, to approach them from the outside to get those guys out of there. A very commonly and popular treatment method for treatment of abnormal uterine bleeding that doesn't have another anatomic source like a polyp or a fibroid or something like that, even if it's because of some types of systemic diseases or just plain old-fashioned dysfunctional uterine bleeding, is an endometrial ablation. There's different types, different flavors, different colors, different procedure types that you can use to have the inside of the uterus treated. And these are the different names of several types of endometrial ablation devices. And a lot of times it's your surgeon or it's your gynecologist who kind of picks which one is most appropriate based on which one they typically use, or which one they're most comfortable with, or based on your anatomy, which one will be most appropriate. Some of the most common ones that are used these days are these top two: NovaSure endometrial ablation, as well as Thermatoids, which is a little fluid-filled balloon that is used to literally slide inside the uterus. Heat is applied either by cautery or by heating the fluid, and it singes that endometrial layer to a certain thickness down close to the level of the muscle or to the level of muscle. So we're trying to destroy essentially all that tissue that we create every month and shed and have a period, so it doesn't come back or comes back very minimally. What can we expect from an endometrial ablation? Well, hopefully at least our periods get to be some sense of normal. If not, they may even be better than that. They may be very light, very infrequent, or sometimes we can even have something called amenorrhea, which means our periods go completely away. So a lot of women say that they love it. It's been great. They have they're completely satisfied with the way that things have come out. But sometimes, just like everything else in life, it doesn't always work perfectly, and some women can end up needing another procedure or another intervention, say a hysterectomy per se, if it's not as successful as we'd hoped it had been. And the one that a lot of us are familiar with, hysterectomies. So about a little under half of the hysterectomies performed in the U.S. in most women are for dysfunctional uterine bleeding, abnormal uterine bleeding, and it's a tried and true method. We know what it is. We take that uterus out, we get rid of the source. There are really definite advantages to having a hysterectomy to take out the uterus. It's definitive. We know that uterus is gone. We know that tissue is never going to come back. There's not going to be bleeding again, and you don't have to have any additional procedures to reduce the bleeding. But the disadvantages are, it is a surgery, and it's a fairly reasonably aggressive surgery. And so you have the possibility of complications from surgery, the possibility of even significant complications from surgery. There is recovery time, so you have time missed from work, you have time missed from school, and the possibility of changing your mind after wishing you hadn't had your uterus taken out. And there's definitely a risk of regret, potentially. There are multiple ways that a hysterectomy can be done. It can be done through the abdomen, through an open incision. It can be done up and down. It can be done side to side, depending on the size and the shape of the uterus. It can be done laparoscopically, so small incisions on the abdomen. It can be done through instruments, either with traditional laparoscopy, where the surgeon holds the instruments, or with robotic laparoscopy, where a robotic arm and device holds the instruments and the surgeon operates from a console. And if the patient's appropriate candidate, the good old-fashioned vaginal hysterectomy, so everything's done through the vagina, things are able to be taken out effectively via that approach, and it saves the patient from having to, or the woman from having to have an incision on her abdomen of any kind. So dysfunctional uterine bleeding, what do we need to know? What do we want to worry about? Well, is it really dysfunctional uterine bleeding, or is there something else going on in there? Is there a fibroid? Is there a polyp? Is there some other systemic disease or systemic problem that can be the source of the bleeding and why it's going on? And then making sure we're not missing something really important. So is there a precancerous or cancerous change that we really should have known about and really should have been addressing? Otherwise, carry on with the treatment methods that we talked about before. Is there anything else that we can do to make sure we're not trying to treat something that we could have resolved more easily via other methods? Is there thyroid disease there that we should have fixed and that would have fixed the bleeding? Or is there a polyp there that we should have fixed and that would have fixed the bleeding? And then ultimately, when it comes down to it, as long as everything else has been ruled out, dysfunctional uterine bleeding is a diagnosis of exclusion. And so it's just a matter of what's right for you, what's right for the woman, what are her needs, what are her risks, what is the most appropriate approach to treat her therapeutically, and then make that decision based on everything included with your doctor.